I'm going to talk about the mystery of sepsis, or basically why your immune system can kill you in certain situations, and try and unravel why this ancient survival system, our immune system, became one of the greatest challenges when we deal with infectious disease. So I'm going to start with a case just kind of made up off the top of my head, but I've seen countless patients like this. So think about an elderly woman coming from a nursing home with foul smelling urine. That might mean that she has a urinary tract infection. When they come into the hospital, maybe they have no fever, their heart rate may be a little bit fast, maybe like 95 beats per minute. Their blood pressure is a little soft, but they're on blood pressure medication. So maybe like 100/70 or so. And they're alert, they're oriented. Maybe they have some dementia, some underlying conditions. And you start the workup, start doing blood work, a urine analysis, and discover this person has a urinary tract infection. You're giving them some IV fluid, some antibiotics, and you're on to your other patients. And you come back and check, and the nurse tells you, oh, her heart rate is up to 110, and her blood pressure is now 90/60. What's happening there? She's developing sepsis. I'm going to get into that. And what might end up happening in this patient is one by one, different organ systems might fail. Her cardiovascular system, in terms of maintaining her blood pressure, her kidneys might become then damaged because of the low blood pressure. And increasingly what you see is this person get into trouble. That's what sepsis actually means. So how does a localized infection, a urinary tract infection in this instance, become a life-threatening systemic illness? And why do some people get this and some people don't? Why do some people recover from sepsis and others spiral into septic shock, where their blood pressure is inadequate to maintain organ function? In sepsis, you have to recognize that the infection starts the process, but the body's response is likely to determine the outcome. When you're talking about an infectious disease, it's always an interaction between the pathogen and the host. That's what's driving the symptoms. That's what's driving the severity. So I'm going to talk a little bit about the ancient origins of sepsis, the evolutionary biology behind it, how modern critical care deals with sepsis, some areas where artificial intelligence might play a role, and lastly, why sepsis remains one of medicine's greatest unsolved problems. So sepsis is something that even people recognize in the ancient world. So the word sepsis, it actually comes from Greek, and it means putrefaction, decay, rot. That's what sepsis means. And I think what it reflects is the fact that you've got a process going on that is basically causing the body to decay. And physicians have recognized sepsis for thousands of years. But a lot of people get this wrong. It's not simply, quote unquote, blood poisoning. That's what you might hear people talk about it as. It's not just the same thing as any infection. Not every infection causes sepsis. You can have a severe infection, but not have sepsis. And sepsis doesn't mean bacteria. You can have sepsis from a virus, sepsis from a fungus, sepsis from a protozoa, a parasite. So it doesn't mean that it has to be caused by bacteria. And sepsis doesn't mean that you have bacteria in your bloodstream. You could have sepsis and not have any bacteria in your bloodstream. So what's the modern definition of sepsis? Life-threatening organ dysfunction caused by a dysregulated host response to infection. So let's break that down. Life-threatening organ dysfunction, dysregulated host response to infection. So I just went slow, so you see that there's multiple components to this definition. They're all kind of self-explanatory, but that's what sepsis is. It is a syndrome, and it represents a breakdown in the relationship between infection and immunity, where you're having damage caused in response to an infection. Thinking about this from an evolutionary perspective, having an immune response is essential to be able to live in a world, in a planet, that's dominated by microbes. What the immune system has to do is understand when it's in danger, when there's danger to the organism. And at this level, just danger, no danger, that kind of binary decision, it's not done at an individual microbe level. It's not, oh, this is E. coli, this is Shigella, this is Salmonella, this is COVID, this is flu, this is histoplasmosis. It's recognizing common molecular signatures. And they have a fancy name called pathogen-associated molecular patterns or PAMPs, PAMPs. And there are certain components of a bacteria, like the lining of the cell membrane, the cell wall, the little tail that some bacteria have that uses them to propel themselves. That's called a flagella. That can be recognized by the immune system. The genetic material of a virus, that can be a PAMP. And what ends up happening is we have these receptors or detectors in our body that then are able to basically recognize these patterns, these molecular patterns, and set off a cascade of events. So what's happening here is like the immune system is not identifying, to use an analogy, it's not identifying the arsonist, that this is, Jones set this fire. It's detecting smoke. And this evolved, this is an ancient form of biological intelligence, and it evolved long before humans existed. It's one of nature's oldest survival technologies. And basically what it's doing is saying there's danger here, and it's not ourselves. So there's lots of molecules that are floating around in your body all the time. When something doesn't belong there, when it's quote unquote non-self, that's what this ancient system is doing. And most of the time, this is going to save our lives. We wouldn't have evolved to be the species that we are without it. But what happens is sometimes that alarm, when the smoke is detected, it gets amplified beyond what is useful and it causes damage. So what happens when the alarm turns on? You get inflammation, which means you're getting increased blood flow. Certain cells of the immune system are going to the site of infection. You're getting blood clotting changes. All of that's meant to deal with the infection, to bring resources to where the infection is and to sort of wall it off, keep it from spreading systemically. But what happens is you can have kind of a maladaptive response where it's too much. And that leads to blood vessels getting leaky. So if blood vessels get leaky, what does that happen? Blood pressure will fall. What happens then? If blood pressure falls, you have decreased oxygen getting to your tissues, to your kidneys, to your liver, to wherever it may be. And when there's less oxygen going to an organ, that organ starts to dysfunction and fail. And then you have a cascade because now you've got a failing organ not doing what it's supposed to do. And you're going to have to deal with that problem too. So for example, when your kidneys fail, certain waste products start to build up in your body and they have negative consequences as well. And you have what's going on here is the immune system is fighting this infection and it's going to injure tissues. Tissues are going to be part of the collateral damage. And when those tissues get damaged, they release danger signals. These are called damage-associated molecular patterns, or DAMPs, D-A-M-P-S. And the immune system is going to respond to them as well. So you've got this feedback loop. Infection triggering inflammation, inflammation causing tissue injury, injury releasing these DAMPs, DAMPs driving further inflammation, and this whole system is kind of going. It's like a microphone feeding back into a speaker. The system is amplifying itself. And what's happening is your organs are getting damaged and you are getting to a point where you're not able to perform, your organs aren't able to perform the functions that they need to, and it's causing you to be systemically ill. So why do we have this system if it can go this haywire? Why hasn't evolution eliminated it? Remember, evolution isn't optimizing for perfection. It's optimizing for survival. There's no designer there saying this is perfect, let's tweak this, tweak that. It's not. It's just trying to do something. Evolution is blind. It's just trying to get people to survive or get whatever organism has whatever mechanism to survive. But think about, if you think about a smoke detector, which smoke detector is safer? One that occasionally goes off while making toast or one that misses a house fire? You don't want to miss a house fire. And if you've got this idea of this, when you're burning your toast and it goes off, it's a nuisance. Evolution is going to favor one that goes off occasionally while making toast so it doesn't miss a house fire that will kill the organism. And think about human history. I've said, there's been 10,000 generations of humans and only 4 generations or so have been able to control infectious disease. So for most of human history, pneumonia killed people. Childbirth infections killed. Wounds killed. Minor injuries killed. And a weak immune response would be fatal if you weren't able to deal with these infections. So sepsis isn't, I don't think of it as a design flaw. I don't think of anything as being designed, but to use that analogy, it's the cost of possessing an immune system powerful enough to protect us on a planet dominated by microbial organisms. The thing is, though, we're getting better and better at treating sepsis, but we can't completely beat it yet. And it's a frustration. Hospitals deal with it. Physicians deal with it. We have genome sequencing, mRNA technology, precision medicine, advanced intensive care. Yet sepsis is still a major cause of death worldwide. Why? Well, sepsis isn't one thing. Every patient differs in the infection that caused it. Is this E. coli? Is it COVID? Is it malaria? Is it staph? Their genetics, how their immune system responds. Their immune response. A very elderly person, their immune response is not going to be that robust. A younger person in the prime of life, they're going to have a robust immune response. Other age-related factors. Do they have comorbidities? All of that plays a major role. Sepsis, even though we're using it as a concept that stands for a lot of different, like a whole umbrella, there are many subtypes of sepsis, and not all of them are the same. Not all of them carry the same mortality rate. And they've done lots of clinical trials trying to kind of stop that sepsis cascade by blocking inflammation, modifying immune pathways, interrupting cascades of molecules that get released during sepsis. Those are called cytokines. And most of them have failed. And what saves lives? Very simple things. Early recognition, early antibiotics, source control, which means draining the infection. Imagine someone has a burst appendix. That means taking them to the OR and cleaning that all out. Or if someone has an abscess in their arm, draining that abscess. That's source control. IV fluids to support blood pressure, to support the perfusion or the blood flow to the kidneys. Medications to increase blood pressure when blood pressure falls. Those are called vasopressors. And generalized organ support in intensive care units. This was all kind of codified in a really seminal paper that came out in 2001 by Emmanuel Rivers, which was called Early Goal-Directed Therapy in Sepsis, where they were trying to basically restore normal physiology, and it had a major mortality benefit. That's since really been incorporated into all the sepsis protocols, and new studies now show that most people are actually doing all of that anyway, and there's not much added benefit. And people have gotten really good at recognizing sepsis in certain situations and treating it appropriately. So kind of sticking to that same protocol hasn't showed the same level of benefit as the initial study. And what I'm referring to is the PROMISE, PROCESS, and ARISE trials. But that's what lots of hospitals use, that initial trial, as the benchmark that they're graded on. And we probably don't need it to be kind of a checkbox, but we do need people to understand the concepts there. Really, right now, what we have is an implementation problem. It's making sure that you know that this person is septic. Once they're septic, there's a cascade that can happen, but it's figuring out who in the emergency department waiting room is going to be septic, who with a mild urinary tract infection or a mild pneumonia is going to have sepsis in 24 hours. That's what really matters. And this is where kind of the interesting, cool stuff is going on with artificial intelligence. Sepsis is really a pattern recognition problem. Early on, sepsis might appear as small abnormalities, a slightly elevated heart rate, mild respiratory changes, maybe you're breathing faster, a little bit faster than normal, subtle laboratory abnormalities, tiny shifts in blood pressure. And if you look at them, each of them like on their own, really insignificant. You say, oh, that's just one little thing off. It's not a big deal. But together they tell a story. And that's where AI is attractive, because AI systems can continuously analyze the vital signs, laboratory values, medications, the clinical notes that people are writing in the chart, doctors and nurses, the imaging data, the x-rays, the CAT scans. And it can do that across thousands of patients simultaneously, and then form kind of like a way to be an early warning system to identify sepsis before clinicians would otherwise recognize it, which could then lead to earlier interventions, faster antibiotics, better triage. This person goes to the ICU, this person goes to the floor. And in the end, improved outcomes. These patients survive at a higher rate. And I think it even goes beyond just detection. You can think about AI identifying different biological forms of sepsis. There's different subtypes of sepsis, and that leads to specific treatments that might work on one subtype of sepsis, but not on another. Or some types of sepsis are going to be more likely to lead to death than others. So when you ask yourself kind of what kind of sepsis does this patient have, then you get precision-guided sepsis care, not one size fits all. Like someone might need immune suppression, someone might need immune stimulation, someone is more likely to deteriorate than another one, so they need better, closer monitoring. Certain therapies will work in one, but not work in another. But remember, data alone isn't going to save lives. You actually have to deal with the implementation problem. You have to be able to actually do those interventions on a patient to actually get a good outcome. So going back to what I said in the beginning, how does an infection become life-threatening? It's because humans have evolved one of nature's most powerful defense systems. I talked about pathogen-associated molecular patterns that detect microbial threats, damage-associated molecular patterns that amplify injury. And remember, evolution favored protection over perfection. And modern medicine does a lot to deal with that kind of lack of perfection by supporting failing organs. And hopefully with AI, we'll be able to recognize patterns earlier, tailor treatment better. But just remember, for thousands of years, sepsis was really understood only through its consequences. Now we can see it in really fine detail. We can see the molecular signals, the immune pathways. You can think about the evolutionary trade-offs. And we're even applying artificial intelligence to the problem. But sepsis still remains one of medicine's most profound challenges because it sits at the intersection of infection, immunity, evolution, and just the whole complexity of the human physiological system. And it also reminds us that some of the hardest problems in medicine aren't just about killing the bug, defeating the microbe. It's about learning to manage the extraordinary power of the defenses that keep us alive.